Pregnant patients with substance use disorder deserve the same level of care as any other patient. When we first got a grant to kind of look into these things, they were looking for an OB champion, to kind of lead the team. And I was kind of voluntold, to be honest with you. It wasn't something that I was like, it wasn't on the top of my list of things to do. It wasn't that I treated them poorly, or just like I didn't really care as much. I was thinking I was doing my job by giving them a list of resources. I said, there are these 2 doctors that are 45 minutes away that do Suboxone treatment or methadone treatment. Here's a couple psychiatrists that may or may not take your insurance, but I felt like that I was doing my job. And then, boy, was I wrong. There's a lot more that we can do.
I became aware of the issue and how profound substance use disorder was impacting our mothers and our infants once I became a part of the pregnancy-associated mortality review. Maternal mortality across the United States, not just in Louisiana, is a public health crisis. And when we look at Louisiana, our rates are exceptionally high compared to the rest of the United States. And we see so many opportunities where we could have intervened from a provider standpoint, from a healthcare system standpoint, from a community standpoint.
If you look at sort of our data, 1/4 of our maternal deaths are related in some way to substance use disorders. It's not just the national statistic, it is in our community. It is in the community you live in. It may be on the street that you live on.
We are seeing more and more fentanyl and less heroin, even in people who think they're using heroin. And because of the potency, a small dosage change and they're dead, or they're in an emergency room near dead. As a family doctor, I see that multi-generationally, that the mother and the child are both affected, and when we can help them both, the family is healthier. And when families are healthier, our society is healthier. And it's not that difficult to treat.
We were trained that that is something that the psychiatrist does, or that's an addiction specialist, that's what they do. But each individual provider that has a license can prescribe medication assistance therapy, or MAT as we call it. It is the best standard, it's the gold standard, it's the evidence-based way we should be treating opioid use disorder. The next thing I would say is be an advocate for screening. We have to screen every individual that comes into care for substance use. I think that a lot of providers believe that we are supposed to check in bodily fluids, either urine or blood, but that is not the way to screen. Use the 4 Ps, using a standardized, validated verbal tool to talk to them, and through motivational interviewing, see if they're contemplating that change. And then we as healthcare providers have a very strong responsibility and I say an opportunity to help connect those individuals to resources.
And I think that a lot of providers are afraid of what the answers are going to be if they screen. If the answer is yes, what do I do? What do I do next? And then feeling responsible if something adverse happens. Find your case manager, find your social worker in your hospital and say, what do I do? What resources do I have? And so I think it's our job in leadership roles in maternal health to provide those resources and educate physicians and providers in maternal health about those things.
It's not just patients who experience helplessness and hopelessness, clinicians do too. And physicians and other clinicians face burnout, they face fatigue, they face compassion fatigue, that's a real thing. And so I think along with all of this, we have to be addressing the clinicians, and they need support to manage what are often really complex issues and concerns.
We do see commonly in the reviews of our maternal deaths a history of trauma. And trauma can be a risk factor for substance use disorders, as well as mental health conditions, anxiety, depression, PTSD. But we also have trauma that happens in the healthcare system. We see in the media, we see in the news, a lot of in particular Black women, not wanting to come into the healthcare system because of the trauma that they have experienced in the healthcare system.
Data shows again and again the impact of bias, and bias impacts the way that we provide care to patients, and we end up providing differential care because of bias. Even if we're screening universally, the data shows that the outcome is different. What that person does with a screen or a screening result is different. So people of color are more likely to be referred to child welfare than their white counterparts, and are less likely to receive evidence-based treatments, including medication for opioid use disorder. And I think any of us can imagine being in a situation where if you face that again and again from people that you're going to for help, and how vulnerable you have to be to ask for help. And then you're shot down, you're shut out, you're judged, you're criticized, you're made to feel ashamed. It's no surprise that someone's going to give up.
I think we see that in patients who show up to the hospital with no care. Patients who come in with poor outcomes, babies who don't survive, problems with the pregnancy leading to early or preterm delivery, and just patients who suffer from a psychiatric component to this disease, who feel like there's no one that's going to help them. And so it's this hopelessness that you see in patients.
The rate of substance use disorder seems to be increasing, and when we've looked at the data, it is increasing in the pregnant population at a rate higher than that of the general population. Part of that is socioeconomic, part of it is the stress that I think are coming out of from COVID, but the numbers are increasing. But at the same time, when we review these maternal deaths, we see pregnancy as a motivating time. We see many individuals accessing the healthcare system multiple times during their pregnancy with either coming in for overdose or actually asking for help.
The number one message that we have with these patients is that we are here for you. We listen. We know what you're going through. You're not the first patient that we've taken care of with this specific disorder, and we know you're not going to be the last. Our number one goal is for you to go home with your baby, that we want you to be as healthy as you can be so you can care for this child after it's born. And oftentimes it's kind of a wake-up call, and they have like this alarm clock now in their head that I'm already 8 weeks pregnant at this point. And it really does work.
And so we need to make sure we're not re-traumatizing them, because we really can be the make or break for individuals ever coming back into the healthcare system again.
I think it's again about patients trusting that we're going to take care of them in the hospital versus them rolling up to the hospital with no care, no established trust. That is a recipe for disaster. And so if we want to impact change in that realm, we've got to be able to have patients come to us, build a trusting relationship, and actually be able to talk to us about what they need.
People who use substances during pregnancy love their children. Parents who use substances love their children. And I think the more that we can all be aware of that, the closer we'll get to solutions that work, that support rather than punish. And we have to make the assumption that patients have faced stigma. We should make that assumption that they've had negative experiences and do more. We have to reach out more, and we have to do more to try to counteract that.
Communities as a whole need our moms. Our moms are the center of families. And if moms are not well, families are not well.
There's obviously patients that need us. We're here to help the patients. So let's get this ball rolling.